All right, so big bucks, no whammies that I can actually have this recorded, but let's hope that this works out. So a few things. So thanks for all hanging on with me. I know this wasn't the most ideal thing to have to go through right now. So it seems as though GCU doesn't want us to record straight to their cloud. So what I'm going to do is upload this to YouTube afterward. It seems as though that's kind of the only thing I can do right now. So hopefully that works. If not, well, we'll get through that together. Okay, so a couple things here as far as kind of how the class is going to be going the rest of the time here. So we have really 3 more weeks-ish. So today, next week with gait, functional activities, and then the last week, really not a class per se, but the last week is our kind of final there. So we're only going to have 2 more live class sessions. So today, which is the 26th, is our spine and posture analysis. Next week, the 2nd will be gait. And then the 9th will be functional activities. If you guys need any help on like the final, I'll be available on the 16th. So I'll have I guess, something like this open for any of your questions. But there's no like actual live class per se for the 16th because there's no material to cover. It's just doing your final. And your final is just your demonstration of skills. So you have 2 things to do with this. And this is really the part that has been kind of the most difficult to try to figure out how to do. So I know I had you guys pick out numbers and I was going to assign you different things to do, but seeing as though that all kind of went to hell in a handbag, I decided to change all that. So what you're going to do for this, and again, this is your final skill demonstration, is you have to do a total of 6 tests. So you need to do 3 manual muscle tests and 3 range of motion tests. What you'll need to do is to demonstrate these on somebody, and then you'll have to record yourself doing it. And then you'll have to upload that, usually like to YouTube is the easiest to do. Or you can, I've had people send me, videos and text messages, whatever, get it to me somehow. But what you do is you need to do a range of motion test for your upper extremity, lower extremity, and spine. And you also need to do a manual muscle test for upper extremity, lower extremity, and spine. I'm going to let you all pick out which tests you want to do or which body parts you want to do. But just remember, you have to do 1 from each category. So 1 range of motion, 1 manual muscle test for each of the 3 body parts here. So you can pick that out. What you have to do and what the attachment says here, this gives you everything you need to have covered. So the ranges of motion are all the same. So you just do the exact same thing for that. And then the manual muscle tests are all the same. It's really the exact same kind of thing that you did for your lab practicals. So for the stuff like, say, positions partner correctly, identifies, uses the landmarks, identifies correct starting and ending position, moves through the correct plane, supports correct limb, aligns the goniometer. All of these, you don't have to explicitly state, because if you do the test correctly, then that means that you've done all those. So the first first 7 points on the ranges of motion, you don't have to state anything. I mean, you have to tell me what the actual test is you're doing. I mean, you do need to do that. But if you do the test correctly, these first 7 things should all be done. So nothing to state there as long as you do the test correctly. The obtain accurate measurement and correctly reports the measurement. With that, what you want to be doing, or what you want to have done, here we go. So if you look on the list of people here, so what you want to do for that is you'll get your measurement, whatever it is, and you want to show me the goniometer or show me whatever devices you're using to measure your range of motion, and then tell me what the actual measurement is. So for example, if you showed me something that looks like this, which is around about 90 degrees, and you said that this was, I don't know, 120 degrees, that doesn't work. So you have to show me, and it has to be within the ballpark of what that measurement should be. And then you have to report the correct norms. So you have to actually state what the normal range of motion is for that given test. Now, the big question is who has access to a goniometer, because that's going to be the biggest problem here. A couple suggestions I have for you if you don't have access to one of these. So the university is kind of locked down, which makes like even like going to the university to get you one a little bit kind of impossible. It was suggested to me that students make their own. If you want to give that a go, by all means, go for it. You could really do it if you just had, like, say, two pieces of paper, or like a piece of cardboard, and you had like just a pin or something in the middle to act as your axis. You could do that. You can use any virtual or online program that will work for you, even if it's something where you just use, say, like a slide rule or some sort of even just angle measuring device. It doesn't have to specifically be a goniometer. That'll work too. And what we'll cover today with the spine, and what I would really encourage you to do with the spine, especially for the range of motion, is that you should use a tape measure, because you'll be able to do range of motion measurements with the tape measure for the spine. That'll make that a lot easier. So again, if you don't have a goniometer itself, you can make one. You can use any sort of web app, anything that you can find that will measure an angle is really what you need. Another thing you could even do is essentially, run someone through the range of motion and then kind of trace the angle of what their joint is, and then measure that like on a piece of paper. That can work for you too. So I'm just kind of spitballing here every idea I have, because the only thing that the department has said was have the students make their own goniometers. So in the case that you don't know how to make your own goniometer from scratch kind of thing, there's that. So needless to say, I'm going to be very lenient with your measurements and how you actually do it. As long as you can show me that you know how to do the measurement, that's going to be the most important thing here. I understand you don't have the tools that you need to make the best measurement, so I'm not going to penalize you for something that you just don't have access to. That wouldn't really kind of work, So there's your ranges of motion. Any questions on that initially?
No, I think we're good.
And the other thing I should say is that you can do multiple takes on these. So as long as you don't, like, say, read off of a script, like, you can do a million takes if you want. Just make sure you upload the one that you want to use. So there's no reason why all of you should not get hundreds on this. I've actually had people in the past that have done this incorrectly, where they actually did a completely incorrect measurement, like did not do what they said they were going to do. That's the only way you're going to miss points on this, is if you don't do it. And really, if you just even go into your lab manual, I mean, you have all of the manual muscle tests, you have all of the range of motion videos in there. Just recreate that. I mean, that's all you got to do. I mean, there's your cheat sheet to it right there. Just copy this exactly. And if you do that, I mean, you know, kind of guaranteed to get 100 there. So that's my best advice to you, is to really just copy exactly what is done on the videos in your lab manual, and that will guarantee you 100%. Like, can't usually give guarantees like that, but if you copy that, obviously you are doing it yourself. You're not just like, say, posting a video of this, but as long as you do that, there is no reason why you guys shouldn't get perfect scores on this. For the manual muscle test, same thing as, like I said, with the lab practicals. So the positions partner correctly, the identifies the correct muscle or muscles involved, palpate, perform the test correctly, and I guess those parts there, along with the plane of motion and the hand placement. So these 1, 2, 3, 4, 5, these 6 portions here on the manual muscle test are all things you don't have to state. So if you perform the test correctly, you have done these 6 points already. The only things that you'll need to state for the manual muscle test is your grade. So make sure you have the correct grade there. The only way you would miss points on this is if you just grossly misidentify what the grade would be. Remember that a grade of 3 means that you can only move against gravity. Like if I touched your limb, so like if you were doing, for example, let's say shoulder flexion, so you're going out for shoulder flexion and I just touched your arm and it fell down, that would be a grade of a 3. If I did shoulder flexion and I even gave any resistance and held up even a little bit, that would at least be a 4. So that's really the only thing you would miss out on, that is if you grossly misidentified there. For the most part, everyone should be able to get 4s and 5s. Now, what you'll need to actually state, you'll need to state the grade, so you need to make sure you state that. You need to state the origin and the insertion of a muscle performing the action, and then you need to state the action of the muscle. So those are the 4 things you need to explicitly state when you do this. For example, if you picked shoulder flexion, you can list any muscle that does shoulder flexion, but you have to use the same muscle for these 3. So you can't go with, let's say, deltoid origin, biceps insertion, and, well, I guess if you got the action wrong, well, that's kind of your own fault. But you have to state the same muscle for your origin, insertion, and action. Obviously, if you're picking a muscle movement, a specific direction of the movement, then you should automatically have the action of the muscle in place. I mean, if you picked shoulder flexion and you said the muscles didn't do shoulder flexion, that's kind of wrong. So there's your little kind of cheat thing to at least make sure you get this correct, is if you're doing manual muscle test and it's for a specific direction or directional movement, you want to make sure you use that exact same name as your action of the muscle. So a manual muscle test, no one should have any issues with in terms of access to being able to do it. you should all be able to do the manual muscle tests without any accommodation. And really it's because you don't need anything to do them. If you don't have, the nice foldable mat table, use a chair, use a couch, use your bed, use the floor. Or just have people just sit up. That's probably gonna be the easiest thing. So if you have trouble, or if you're going to have problems with, say, somebody needing to lay down either prone or supine, then maybe pick a different test that doesn't involve that. So probably the easiest thing for you guys to do would be to pick a test or a series of tests where you are standing or sitting, because that'll make everything really, really easy for you. And again, multiple takes on it, so you can do as many as you want. Just make sure that you're submitting the one that you want to use for grading. Since there's 6 measurements to be doing, you can do this one of 2 ways. You can do everything back to back, so just 6 in a row and just have one video to do it all. Or you can upload one video for each of these. So you can do a 30-second video for each one, or a 5-minute video for all of them. Doesn't matter, just as long as you get them all completed. So realistically, like I said, this should be easy 100s for everyone. I mean, like I said, go back to the laboratory manual, do exactly what the video shows you to do. That's the easiest way to get a perfect score on this. Now, the other aspect of this is this benchmark here. So this is the second part of your final. The first part is the demonstration of skills, and that's where you upload the videos. You're just doing a video upload, that's it. The benchmark evaluation is that you are writing a paper, and I say writing a paper, but that's kind of I'm using a loose definition of that. 500 to 1,000 words. It doesn't have to be that long. It can be longer if you really want it to be, but I don't know why you'd want it to be that much longer. What you're doing is you are going to compare and contrast 2 of your 3 body parts. And you're going to do that in regards to range of motion and then to manual muscle testing. So what you'll do is you take 2 of these 3 that you've picked for the range of motion, and you are going to write about these 4 things here, comparing the 2. So obviously you're comparing either the upper body to the lower body, the upper body to the spine, or the lower body to the spine. You want to make sure you include these 4 points: motion, the planes of movement, the joint type, and the normal ranges of motion. So you want to just compare the 2 for that. Pretty simple. I mean, you could probably knock this out in really just 2 paragraphs. And then you'll also do a comparison of 2 of the 3 body parts for the manual muscle testing. It doesn't need to be the same body parts as range of motion, but again, what I would strongly encourage you to do is pick the same range of motion as you're going to do for the manual muscle test. So, for example, if you're going to do range of motion for, let's say, shoulder flexion, it would probably be a good idea to do a manual muscle test for, say, like deltoid. Just something to keep in mind there, because that's going to make it so much easier for you, since you only have to then remember 1 muscle group instead of 2. And then when you compare these 2 for this written part, you have these 3 things here: the muscles involved, the joint involved, and then the actions of the muscle. So really straightforward there. No APA style is not required, so don't worry about that. If you're using any sort of outside sources, make sure that you do cite that. So you still can't just plagiarize, but you don't have to, like, for example, you don't have to, like, say, cite the lab manual if you're telling me that, I don't know, pronator quadratus pronates the forearm. You don't have to cite anything like that. If you're telling me something that you get from an outside source, yes, you're expected to still use a citation for that. But that's what it means by APA style is not required. So what I would strongly encourage you to do is use, again, the lab manual for all of your information that you need, because that'll give you everything you need to know. Just make sure you paraphrase. So again, you can't just copy, paste, or plagiarize. Put things in your own words. If you just use the lab manual, you don't have to cite anything. If you're using any outside sources, then yes, you do have to cite stuff. So hopefully that gives you a pretty decent idea of what you need to do for your final. The reason why I spent, a whole 25 minutes on this is because the demonstration of skills is worth 120 points and the written portion's worth 80. So if you add that together, that's 200 points, and that happens to be 20% of your grade. So none of you have a perfect 100% in class, which means if you didn't do this, the best grade you would be able to get is a C+. So that's why I'm spending so much time on this, because this is worth so much of your final grade, and really it should be an easy 100 for you guys. So as long as you do it and you don't really completely mess it up, like, this should be easy A's for everyone. So hopefully that helps there. Any questions on that?
I think we're good.
All right, so we're going to let Bowen be our official spokesperson.
Why change anything now?
Okay, getting in the spine here, and obviously you don't have, or you're not going to be able to do a lab per se. What you're going to be responsible for is making sure you turn in the movement analysis and making sure you complete the post-lab questions. As far as the postural assessment, you should be able to do this regardless of your access to anyone. There's two things you can do with this. You can actually do a postural assessment of somebody else, like, say, a friend, family member, whatnot. What you're going to do is you are going to go over all of their body positions and looking for any anomalies. I'll go over this a little bit more in detail when I cover the PowerPoint here. But you're going to go over this, and what you'll do is you're going to write down any anomalies you see. So for example, let's say, all right, let's go here. For the lateral side, external acoustic meatus, that's your ear or your ear canal. Something along the lines you could say is head tilted anteriorly. If there's nothing wrong, so if that body part is fine, you just don't put anything. So you're only going to write stuff here when there is something that's an anomaly. So you don't have to go through and say, like, this is okay. No, don't do that. Only write down stuff for the posture analysis if there's something wrong. So again, I'll explain all this more in detail, but that's what you'll need to do. So the three things you need to do again: movement analysis, the posture assessment, and the post-lab questions. Now, with the actual spine itself, there's a ton of stuff that goes along with this. And this is definitely it's definitely a lot easier to do this if you have visuals, or if, like, we were actually in class to do this. So again, I understand that you're not going to get the full appreciation of it just by listening to me talk to you or watching on the screen here. But we're going to do the best we can with what we got. When we talk about the spine, you're really referring to the vertebral column. So the spinal cord itself is inside kind of the vertebral column. Now, if you look at this here, you can kind of see how there's these nice little holes here. And remember, anytime you have a hole in a bone is called a foramen. Well, you have this nice channel that goes here, and this is where your spinal cord actually goes. So this is anterior, so that side's anterior, this side's posterior. So all of these bones that stick out, that's the bones you see protruding in your back. So that's what you would actually see visualized with your spine. But right in the middle is where your spinal cord goes. So it stays in this nice channel for you there. The vertebral column is set up into really primarily 3 sections with like kind of a 4th at the end. So cervical, thoracic, lumbar vertebrae. The mnemonic to remember is you eat breakfast at 7, lunch at noon, dinner at 5. Hopefully you can read all that, which I'm pretty sure you can't. But 7 cervical vertebrae, all mammals have 7 cervical vertebrae. So that's the same for everyone. Thoracic, you have 12. How you tell the difference between a thoracic vertebrae and a lumbar or a cervical is all of your thoracic vertebrae have ribs. And then your lumbar vertebrae are your biggest ones, 5 of those. Now, at the very bottom, you have your sacrum and coccyx. These are all fused. So you actually have 4 fused bones for your coccyx and 5 fused bones for your sacrum. One thing a lot of people tend to get a little bit mixed up on is where the actual location is of their spine. So because your sacrum and coccyx are a concave facing bone set, a lot of people think that this goes clear down like to the bottom of your butt, which it doesn't. If you just feel around to where the start of your ass crack is, that's where your coccyx is. So your coccyx or your tailbone, that's at the very start of your butt crack. So that's where your spine is ending. So again, if you are looking at thoracic vertebrae, they all have ribs attached. Now, when you get to the bottom here, especially for like ribs 11 and 12, those are floating ribs. They don't have any connectors to them. You're not going to feel them in, say, like, you know, your rib cage, but you can feel that in your back. So you should still be able to feel all of your ribs really down to where those are. So where your ribs end, that's where your thoracic spine ends. Your thoracic spine starts at your sternal notch. Your sternal notch is right here. So just so you know, I have an iPad that I'm using for the video because my home computer doesn't have a webcam since it's a desktop. So if I'm in all different weird positions, I'm trying to do my best to make sure you guys can all see me. But sternal notch right here, that is where you have the start of your thoracic vertebrae. Everything from there up, cervical. So thoracic starts there. It's going to end where you get to your last rib. So if you even feel down on your ribs and right where you feel the bottom of your rib cage, that is going to be rib 10. So where you feel that, is rib 10 because you can follow that straight back up to your sternum where that connects. So the only way to feel 11 and 12 is to go to your back, and then you'll have to kind of palpate pretty heavily to feel them, but you should be able to feel your floating rib bones at the bottom of or the base of your back there. Or I shouldn't say the base, but kind of the lower middle portion of it. Your thoracic vertebrae don't move so much. Because these have ribs connecting, both back and front, it limits how much range of motion the thoracic vertebrae have to move. They still will move somewhat, but they move a lot less because they're in a full circle, so they're enclosed. There's not a whole lot of freedom of movement there. Your neck and your lower back move quite a bit. I mean, all of you can hopefully, bend your neck, turn your neck. You can bend or tilt to the sides. So you can move your cervical and lumbar vertebrae pretty good. The thoracic, not so much. Now, every vertebrae has a name. Typically, that's just a number. The ones that are actually, so every vertebrae has a number. The only ones that really have a name proper are going to be your top two. So C1 and C2 is your atlas and your axis. So atlas, named after I think it's the Greek guy who had to hold up the world kind of thing. Because this has to support your skull. So this sits directly on the base of your skull. The axis is C2, so C1, C2, is called the axis because you have this thing here called the dens. The dens is just this little kind of protruding notch that sticks right into the base here of, it actually sticks right in the base here of the posterior arch of the axis, the atlas, and it acts as a pivot point for it. So it's like if I have my pen here as my the dens or the axis, and this here were, say, my atlas, it sticks right up into that and it holds that in place. So then it can then help to assist with turning it. Don't worry about all the ligaments here. All of the ligaments you have are virtually all the same in terms of what they do for really everything. So you're going to have ligamentous support all throughout. Let me see if I can pull the better picture here. Yeah. So you're going to get ligaments that go all the way up and down the spine, and they attach every which way. So don't worry about everything with that. All you need to know is that the ligaments are going to essentially just hold your vertebra in place. That's really about it. Now, what can be dangerous about these is if they calcify. You don't think of like ligaments calcifying, but in your spine, they can. If those calcify, you can actually end up, like, say, paralyzing yourself. There are, like, say, horror stories about people that go to a chiropractor and die because of this. So for the most part, chiropractic care, I'm hesitant to say chiropractic medicine, is not something that's going to harm you, but it's definitely contraindicated for people that have either, say, spinal stenosis, if they're in advanced age, or they have a lot of osteoarthritis, or they have osteoporosis in their spine. Because if these calcify here, so this is posterior, this is anterior, so you're looking kind of straight from the posterior side. These ligaments here can calcify. Well, right underneath those ligaments is your spinal cord. If you were to try to, say, make an adjustment or crack your back, if those were calcified, you can actually have this break off and pierce your spinal cord. So if you have arthritis in your spine, you really shouldn't be going to the chiropractor. And truthfully, chiropractic care is only really truly beneficial for people that have low back pain relative to typically to postural problems or muscular imbalances. So like if you have a herniated or a bulging disc, chiropractic care is not going to do anything for you. If you have nerve impingements, decompression therapy may be able to help, but chiropractic care proper isn't going to do anything for you. So just want to kind of make that kind of known there. So again, don't worry so much about all of the different ligaments that are involved. There's a ton of them. They're all there primarily just to give you extra support. Your cervical vertebrae are your thinnest bones you have, or the thinnest vertebrae you have. Thoracic get bigger, lumbar are the biggest. And then remember, with all your thoracic vertebrae, you attach a rib to them. Now, your intervertebral discs, these are kind of important. These are essentially the cartilage that cushions your vertebrae. So this is anterior, this is posterior. This here is your spinal cord. And these are your intervertebral discs. You have these intermixed in between each set of vertebrae there. These act as kind of a twofold kind of purpose for you. So the first one is to give you support, and it helps to act as like a cushion really for your vertebrae. The second is to allow for motion or movement within the vertebrae. If these were static, like they just stayed just like that, and they were just like a piece of cartilage, like say your meniscus is or your labrum is, and you moved your spine, you would constantly be impinging this, and you would constantly get like say bone on bone problems. It wouldn't work. So what happens is you have this nucleus here, which will actually shift all around to accommodate which way or which direction you're moving. So, I mean, it's going to move opposite, obviously. So if I am sitting straight up and say I tilt my head to the right, that nucleus is going to shift towards the left to provide more cushioning to that side. It wouldn't shift to the right because then I would have bone on my left side. So it shifts over opposite of the direction you move. Now, normally, this is kind of like really like a piece of silly putty, but it's a little bit more structurally sound. But kind of really the best way to think of it in terms of what it would actually feel like is kind of like silly putty. If you have problems with this, something like a disc herniation, bulging disc, what happens here is that instead of this being like silly putty, it starts getting almost like, say, like stale bread. So something where, you know, bread should have a nice soft, unless it's like a French loaf, but if you have like a regular, whatever, loaf of white bread, that should all be squishy and very giving. When that gets stale, it gets tough and brittle, and you can actually crack pieces of this. So you can actually get like almost like a fracture in this, where it cracks due to having really a degeneration of the disc itself. If you get a disc herniation, what happens here is that this nucleus leaks out, and it can go either anteriorly or posteriorly. If you were to have a lateral herniation, you really wouldn't know. And that's mostly because it's not impacting anything. The only time you're going to know that there's a herniation is if it's anterior or posterior. That's because a posterior herniation is going to put pressure on the spinal cord. An anterior herniation is going to cause bone on bone for your posterior vertebrae. So you're going to have pain with that. This usually will resolve on its own. If it doesn't, the only real thing to do is to get surgery for it. If you have a fundamental breakdown of the disc itself, even doing things like spinal decompression aren't going to help. It's going to temporarily fix things, but it won't really give you any long-term solution. And then if you ever see the term stenosis, stenosis means you have a narrowing of your spinal column. So stenosis would mean that this column here closes in on itself. And that would mean it would put more pressure on the spinal cord. All right, as far as our movements, you have really 4 basic movements for your spine. You have flexion and extension. And by flexion extension, this is forward flexion. So I can bend forward for forward flexion. I can extend backwards. Then I have lateral flexion. Lateral flexion and rotation, I need to state which direction I go. If I laterally flex to, let's say, the right side, I'm moving my head, neck, body to the right. So putting my ear on my right shoulder. Left lateral flexion, ear on left shoulder. I can laterally flex my lumbar spine if I just lean one way or another. And then rotation, pretty simple. I just turn to look, or I'll turn my entire body to rotate. While you have, like I said, you have a little bit of movement of this in the thoracic spine, the majority of your movement comes from the neck or the cervical spine and the lumbar spine. Those are the 2 parts of your spine that move the most. Now, flexion, extension, hyperextension. This is all exactly the same as any other run-of-the-mill flexion extension. So, plane of movement, what is that? So what plane am I going to be able to do flexion and extension in?
The sagittal plane.
There we go. Oops. If I do lateral flexion, what plane would that be? So remember, lateral flexion, I move
Frontal.
Yep, there you go. And then rotational, surprise, surprise, transverse plane. All rotational movements are always transverse. The lateral flexion is an exception to the flexion extension rule because it's going laterally. So there you go with that. All right, muscles you have. All of your big muscles are going to play somewhat of a role on the spine just because they're going to connect to it. The biggest muscles that are going to impact your spine are going to be your traps, levator scapula, and a little bit with your rhomboids. These here, your rotator cuff and teres major, don't work on the spine at all. So don't let those confuse you. They don't do anything to the spine. You have to connect to the spine to make it work. Lats a little bit, but not so much. They're more of a passive movement. Deltoids don't. So traps and levator scapula, that's your biggest ones, because those are going to help extend your neck. Your scalene muscles, which are anteriorly, and your sternocleidomastoid, so that's if you like flex your neck and you see like on the sides here, you get things sticking out, that's your sternocleidomastoid. That's going to help with lateral flexion and front flexion. Traps primarily do extension of the neck. And like I said, sternocleidomastoid flexes the neck and does both rotation and lateral flexion. Here is your much more important thing though. So your erector spinae muscles, you have three groups of them, or three muscles that make these up. So your iliocostalis, your longissimus, and your spinalis. So just like your iliopsoas is two muscles together, your iliacus and psoas major, the erector spinae is three muscle groups together. So iliocostalis, longissimus, spinalis. Trying to separate these is virtually impossible. All of these originate all on the spinal cord. They all insert onto either the head or onto the rib cage. So the origin of all of these is going to be somewhere on the spine. The insertion is going to be either skull or ribs. The primary role of these is to keep you upright. So if you remember like an erector set or I don't know, anything else, this keeps you upright. Because they're located posteriorly, they are going to primarily work for extension. So your abdominal muscles will primarily assist you with flexion. Your erector spinae muscles will assist you with extension. But this is extension of the whole spine. If you notice, these come all the way from the coccyx up to your skull. And if you look, these are all kind of like spaghetti string looking like muscles. So tons and tons of them. This is what makes them so effective, but it also makes them so vulnerable to injury. If you hurt your back, especially if you hurt your lower back, that's not, a disc issue or a nerve issue, you're hurting the erector spinae. Because these are so thin and kind of just almost like spaghetti strings, it makes them very susceptible to injury. You can bend over and pick up a piece of paper the wrong way and pull one of these muscles. But these are your most important muscles for your spine as a whole. So if you're doing any analysis of the spine, these are the muscles you need to primarily focus on. The deep muscles, don't worry so much about any of the splenius muscles. The scalenes are really deep to your sternocleidomastoid. So your SCM is right here. Your scalenes are underneath it. These are going to do a similar movement to these. They're all synergist though. So your deep muscles are going to be your synergist muscles. You have muscles lining all of your vertebrae. Now, your abdominal muscles are primarily going to be assisting with rotation and lateral flexion and will be primarily responsible for forward flexion. You have 4 abdominal muscle groups. So you have your rectus abdominis, your external oblique, internal oblique, and transverse abdominis. And this is how they are arranged from superficial to deep. Rectus abdominis is your six-pack. So that's what you would see if you had six-pack muscles. This is also bacon. So if you're eating bacon, this is what you're eating. Your external oblique is going to be your next deepest muscle, or I guess your next most superficial muscle, your internal oblique underneath that, transverse abdominis underneath that. So with external oblique, and first thing you should note, I guess, with rectus abdominis, you notice the fibers go up and down. With the external oblique, they go side to side, almost kind of like at a bit of an angle. Internal oblique, they go side to side, and then transverse abdominis, they go side to side. These muscles are all going to move in the direction that the fibers are facing. So because rectus abdominis is up and down straight in front, it's only going to move you straight in front. That's why if you're doing crunches, you are primarily targeting rectus abdominis. You get a little bit with the deeper ones just because of the vicinity or the proximity they are to it, but not so much. With your deeper muscles, because these are all running side to side, these ones are going to be affected from rotational movements and lateral movements. So if I'm doing, like, say, crossover crunches, if I'm doing, say, oblique crunches, anything where I am moving my core off center, I'm going to be targeting the obliques and transverse abdominis. And again, it's all because of the direction that the muscle fibers face. Your abdominal muscles move in the direction that the muscle fibers are going. It's probably the easiest way to think of it. Quadratus lumborum, we've talked about this already, but this is going to be one of your deep posterior core muscles. So this attaches to your posterior superior iliac spine, and it inserts into the 12th vertebrae and the first 4 lumbar vertebrae. Now, things that go wrong with the spine: kyphosis, scoliosis, and lordosis. This is something that is a lot easier to, like, when you can actually visualize it. Now, if you have kyphosis, that's where you have an abnormal curvature of the thoracic spine. This used to be called a dowager's hump, but you'll see this from people that have either severe arthritis or they have really poor posture. One of the biggest problems you'll see with people that have this is that it tends to be the older population using walkers. And because people will use walkers by, say, they'll have the walker out in front of them and they'll be leaning forward on it. So they'll be leaning, trying to get myself forward with the walker, and that's where you get that bent over, that hump appearance. Instead of having them standing upright with the walker, they always lean forward with it, and that's where you get or exacerbate that issue there. Lordosis means you have an exaggerated curvature of the lumbar spine. So these are people that have an excessive, like, say, pot belly. And it's not necessarily because their stomach is big, but they have an excessive curvature of that lumbar spine. There's a few different underlying causes that could be, but just kind of remember that that's what really it is. And then scoliosis is more of a, I don't want to say it's a generic term, but it applies to the entire spine, minus the fused portion, so minus the sacrum and coccyx. Scoliosis is a deviation left or right. So if you notice here, this spine looks relatively straight, whereas this spine, you can see how this has a huge deviation there. So scoliosis is either deviation left or right. The most common place this affects is the thoracic spine, but it can affect any part of your spine. The greater the degree of deviation you have, the worse off you are. If this is caught early on, so if you catch this typically like in childhood, usually you can wear, like, say, back braces that will help align the spine. So as you grow, it'll help to keep your spine moving towards better alignment. if you're done growing, so if you get completely through your growth spurts, you're done getting taller, you really can't do much of any sort of conservative treatment to correct this. The only thing then you can do is to have like a surgery on it. So what would happen is if you had surgery on this, you would go in and you would actually get these fused together. So you would get big portions of your back fused together so that it doesn't move. The problem with this is that scoliosis left untreated will continue to get worse. And you can kind of just conceptually figure that or see that if I have this big of a deviation in my vertebrae, how that can negatively affect my spinal cord itself, let alone how my muscles feel, because it's going to cause a lot of pain if you're this deviated. So getting a fusion surgery done prevents any more movement. The only problem is that it limits how you actually can move. Once you get a fusion surgery, you're done. Like that's it. You can't do anything else. So a fusion is done to somewhat correct because you can move the spine back into a better position, but then it's locked in place. You can't do anything else for that. Now, last thing I want to touch on here is our postural analysis. Rule of thumb with a postural analysis is that if it looks wrong, it probably is wrong. So that's where you get issues with this. This thing here, the plumb line, that is a fake line that should go straight up and down the middle of your body. And this will be seen, you can use this both anterior and posterior and laterally. So if you were looking at somebody from the side, you can have a plumb line that goes straight up and down like that. But a plumb line is just there to tell you what the straight or normal reference point should be. Now, you want to do a postural analysis from 3 sides. So anterior, posterior, lateral. While you should do both lateral sides, typically you're going to be able to see on one side and infer what's going on the other side. The things that can go wrong. Okay. If I'm looking posteriorly, primarily what I'm looking for here is lateral deviations. So for a posterior analysis, you're going to see things that are going left and right. Same thing anteriorly. Anteriorly, you're also going to see things that go left and right. That's going to be your major moving point for that. If I look laterally, that's where I'm going to see anterior posterior. So that's where I'll be able to see the anterior posterior deviations. With a anterior or posterior view, I'm going to see lateral deviations. The points you want to look at. If I'm looking anteriorly or posteriorly, I want to look at the skull and the neck to make sure these are in alignment, the shoulders, the pelvis, the knees, and the ankles. All of these should be, relatively speaking, in straight alignment. If you see someone that, say, like deviates to one side or another, that's suggesting you have either some sort of muscular imbalance, you have a potential anomaly with, say, like your spine or development of your bony structures, or you have really, like, just say poor posture is going to be a big one. So you can get quite a bit of deviation on the spine just from sitting improperly. Where you look at from the side is this here. So that's that external auditory meatus, which is really just the ear canal you have. You want to make sure that that sits over your shoulder which sits over your pelvis, which sits over your knee, which sits over your ankle. So everything should be in straight alignment. The most common thing you'll see for almost everyone is you will see an anterior flexion or kind of an anterior type tilt to the cervical spine. Almost everyone has this. The way you would judge this proper is having someone stand up against a wall. If you have them stand against the wall, you'll see if they have to forcefully put their head back to make their head touch the wall, because that suggests that they're anteriorly flexed with their neck. And let me just make sure I go through all the different positions here. Okay, so my anterior view here, head, nose, chin, ears, clavicles, acromion, rib cage, waist, upper extremities. All you're looking at here is, are these in alignment? So do these line up the way they should, or are they off? So is like one knee up here and another knee down here. I know that's over exaggerating, but you get the idea. You also want to make sure that these have the same distance from the trunk. So if you had one arm that was, say, going out farther than the other, that would be problematic. That means typically that there's a muscular imbalance, but it also could suggest that you have either a bony imbalance or there's a nerve issue. Now, don't let this here confuse you for the lateral view, because this isn't really how that should look. But the reason why the arms are positioned in extension like this is so you can better or more easily see the whole side of the body there. That's the only reason why that's like that. These should be just at your side in anatomical position. But like I said, they're out here in extension just so you have a better visual representation of this. For your posterior sides, don't worry so much about the acromion. You're going to see anything you need with that with the clavicle on the front. So don't worry about that. Acromion will be really the same as the clavicle. Your scapula, those are the ones that you're going to see the most imbalance with here. Whether you can see one that moves outward in kind of a winging fashion, you can have them coming outward this way, you can see them going up or depressing down. So your scapula and your pelvis are your two big, well, along with your shoulders, I should say. So for a posterior view, the most important things you're going to see are the scapula, I mean the spine obviously, and the waist. So that would be these two here. Gluteal level, you're going to look at that for Trendelenburg. Knees and Achilles tendon and heel alignment. If you have, sorry, let me just pull. See if I have this up here real quick. Oh, here we go. For the foot and ankle, this is what you'll look at for a static position. So you're looking at pronation and supination. So that's what you'll see when someone's standing neutral there. For the anterior view, the head and neck are most important, so whether those are moved or moving any other way they shouldn't. Your clavicles, waist, and the upper extremities, those are the big ones. And then with the waist, that goes into the iliac crest, ACIS, And then with the lower extremity, you're going to look for the patellus, whether you have that knee varus or valgus. So if you have the bow legs or the knee knockers. Foot arches, okay, but that's going to be something that'll be more easier seen posteriorly. And foot position. With foot position, you're looking at if my feet are rotated outward or inward. That's the biggest thing you'll see there. And then lateral side, that external acoustic meatus, so anterior tilt of the head. With everything laterally, what you're making sure you see is everything connecting in a line here. And I drew that way off. Here we go, kind of. So your ears should be over your shoulders, which should be over your hip, which should be over your knee, which should be over your ankle. That's the major thing you will see from a lateral view of the posture, is if anything is off there anteriorly or posteriorly. Typically, you're going to see more anterior displacement than you will posterior. All right, post-lab questions. That should be pretty straightforward there. All right, and then sitting in a chair with proper posture, and again in a slouch position. So proper posture, we're just talking about the upper body. So everything from your butt up, doesn't really matter what you do with your legs. So don't worry about your legs, just worry about what you're doing with the upper body. Pick 3 abdominal muscle exercises. That's pretty self-explanatory there. And then how do you improve your posture? So 3 things you would tell them to do. This can be something from, and don't worry about this whole researching bit. Don't worry about all that. If you want to do it, by all means, go for it, but not necessary at all. So make sure you just have 3 things there. Now, in terms of what these would look like, what I first want you to eliminate is anything that says inclinometer. So it says inclinometer, get rid of it. Because you guys don't have an inclinometer, and I don't expect you to go and say like buy one or something. Can't really make that on your own. Okay, so inclinometers all gone. Goniometer stuff. Cervical flexion with your goniometer. So cervical flexion means I'm going forward. What I would be doing with this is I would take my goniometer and I put it at 90 degrees. And what I'll be doing is I'll take the axis and I put it right where my ear canal is. I want my movable arm to touch my nose. So hopefully you can kind of see this. Movable arm touches my nose. The fixed arm is going straight up and down. And then when I go into flexion, I will move straight down and hold that movable arm so it follows where I'm at there. That's how I'll get cervical flexion with the goniometer. Cervical extension with the goniometer, exact same thing, exact same setup, except I go upward. So because you start at 90 degrees, so I'm starting here, 90 degrees is my 0, okay? So start at 90, and then when I go up, so for myself, I'm looking at right now going to, I mean, I just kind of threw it up there, but it looks like about 105 degrees. So you can kind of see that there. So I started here at 90, I went up to 105. That would mean I had 15 degrees of extension. And granted, I'm just kind of just doing that real quick for you. But again, starting at 90, 90 is your 0. You take whatever your end range of motion is. So in my case, it was 105. Subtract 105 from 90 gives you 15 degrees. That's what your movement is. So cervical flexion, cervical extension, real simple. Cervical side bending is fairly easy. With the side bend, now it's going to be hard to, I can't really kind of do this on my own that well, but what you would do is you would position your axis to go at C7. So where you can tell where C7 is versus T1 is the first big bump you feel. And I'm hoping you guys can all see me. That first big bump you feel is usually going to be about C7. The second big one you feel will then be T1. So it'll be approximately in alignment with where your sternum is, or the sternal notch is. So you want to be just above your sternal notch on your neck. That's where your goniometer would go. You can do one of two things with the fixed arm. You can stick it straight up or straight down. I like to have it straight down because it gives me a very easy way to hold this, because all I do then is take the fixed arm and I hold it straight against my spine, and that won't move. And then for the movable arm, I stick it just straight up, and then as I go lateral, I just keep that dead in the middle of my head there, and that's how I get my reading. So there's my side bending. The cervical side rotation, this one's a little bit trickier. So with this, you're again going to start at a 90-degree position. And now you take the axis and you put it straight on top of your head. You want the movable arm to be going straight in alignment with your nose. You want the fixed arm going straight in alignment with your ear. So you'll start there, start at 90 degrees. And then as you move, you want to, as you rotate, you want that movable arm to follow your nose. So again, you're starting at 90. So I started right here at 90. I moved all the way over to approximately like, did I go to like 40? Yeah, I went to about 40. So I went from here at 90 all the way to 40. So 90 minus 40 means I had 50 degrees of movement there, 50 degrees of rotation there. So that's how you do the rotation with a goniometer. All right, the thoracolumbar flexion with the tape measure. All you're doing here, and probably the easiest way to do this, is you are starting standing up and you have your hands at your sides. And what you'll do is you measure somehow. Here we go. I want to measure where the tip of my middle finger is down to the floor. Okay. And then what I'll do is bend over to touch the floor. And however close I am to the floor tells me what my measurement is. If you can, say, go past touching your toes, it all counts as being technically 0. So you want to have less than a 2-inch gap between your hand and the floor. If you're doing extension with the tape measure, so thoracolumbar extension, So forward flexion, you're bending over, touching your toes. You are measuring the distance between your fingertip, like your middle finger, and the floor. With the thoracolumbar extension, what you would do is you would take a tape measure, and I should have one of these. Yes. Another way you guys can do this is if you have like a piece of string or rope, anything to measure it. But what I would do is I take my tape measure and I put it on my T12 spine. So again, when I feel down my neck, the first big bump I feel, that's C7. The second one I feel is going to be T12. That's where I want this to go. And then you are going to feel for the base of your spine. So the easiest way to do this is if you feel for your posterior superior iliac spine and go straight over, typically where like you have dimples in your back, that's kind of the area you want to be at. So right at the bottom of your spine there. So you want to try to get above the sacrum. There we go. And if you feel, you can feel your sacrum real easily in your lower back. Just above that is where you want to be. So for myself, that's right about here. So what I do is I stand straight up and I measure the distance from here to here. So however long this is my initial measurement. So for me, I am measuring about about 22 inches. So that's what I would measure there. So that's my initial measurement. So you keep that in mind. And then I'll go into extension. So you go into extension as much as you can. And then you notice how there's all this slack now in the line. So now I want to straighten that line or make it taut against the spine there. So where I want to make sure it's taut against my end of my lumbar spine from my thoracic spine. And the difference I get there, which should be smaller, is what my measurement is. So I would take that initial, whatever, 22 inches, and then subtract it with what my second measurement is. And that tells me how much movement or what my range of motion is for thoracolumbar extension. Thoracolumbar side bending with the tape measure, exact same thing as flexion. You start with where you're at with your hands at your side, and you'll lean over one side, measure your middle finger to the ground, and then same thing with your other side. So you should have two measurements for that. So that's kind of the best I can do for you in terms of showing you how to do the range of motion measurements for this. Again, make sure you eliminate anything that says inclinometer. We're not going to do that. Any questions on the ranges of motion? And again, these are all right in your lab manual too. So I'll give you your manual muscle test and your ranges of motion. And again, ignore the double inclinometer or any of the inclinometers. We're not going to do those. All right, for the manual muscle test, thoracic and lumbar trunk extension. What you do here is you lay prone on table, floor, whatever. And you as the tester are going to hold on to the your partner's legs and they are going to put their hands kind of over their head and go back into extension. With the lumbar extension, you want to try to get them to extend from the lumbar spine. So you want to get them to extend really from their hips kind of issue there. So you would start them, like if this is my hips, you want to have them bend backwards at the hip. If you're doing the thoracic trunk extension, you want to try to get them to keep their abs on the ground. So you're just going back then with your thoracic spine. That's the major difference with that. And then if they can hold that position for approximately 5 seconds without moving, that gives you a grade of 5. All right, for Quadratus Lumborum, that's going to be side bending, Rectus Abdominis, and your obliques. Okay, so Quadratus Lumborum, I'm not too worried about it for that. So do it or don't, that's okay. I'm not too worried about it. For your Rectus Abdominis and your obliques, what you do with these is now you are having someone lay supine, and there's 3 different arm positions you can have. So you can have, if I'm, again, imagine I'm laying supine, I can have my arms at my sides, I can have my arms crossed in front of me, so I can have them like this, or I can have my hands at the side of my head. If you are, and at the side of your head means that they're at the side, you're not putting them behind your head to help yourself out. But what you'll do is, this will give you a grade of 5, this gives you a grade of 4, this gives you a grade of 3. For the Rectus Abdominis, you are doing a forward crunch. The position you have to get to is your shoulder blades need to be off the ground. So if a person cannot get their shoulder blades off the ground, that would actually be a grade of 2. If they can just get off their shoulder blades off the ground in any way, that's at least a 3. If they can get their shoulder blades off the ground and hold for 5 seconds with their arms across their chest, that'll be a 4. If they can do it with their hands at their side, hold for 5 seconds, that's a 5. Obliques will be the same thing, but instead of doing a forward crunch, you're doing to a side. You're going to a side there. So you'll have one side, other side. So you have 2 sides for your obliques there. So again, I know not the most ideal way to do this, but hopefully now at least you have a somewhat general idea of what you should be doing with the spine, and hopefully you got at least a good idea with what's expected of you for at least this lab and your final project. So that is all the new information I have for you there. I know I talked for way too long, but thank you all for getting through that with me. If you guys have any questions, I will stick around till you all leave. If not, I will see you guys on next Thursday. We'll be going over kind of gait analysis. And then the week after that, we'll be doing your functional anatomy or functional and sporting things there, which won't be all that long to do. And then that'll be that. So you have today, next week, and the week after. So the next 2 weeks, we'll have classes. 3 weeks from now, we're not going to have class per se. I'll be here for you. So if anyone wants to hop on to get any help, but that'll just be doing your final project. So that's everything I got for you there. So thank you for getting through on me, and I will see you all hopefully next week.
Thank you, Professor.
You're welcome.
I have a quick question.
Yeah.
So for the lab, what we're turning in, do we still need to do like the action origin insertion for the manual muscle tests, or do you just want like the first part with the what is it, the planes of motion, and then the posture analysis, and then the questions at the end? Is that
So
correct?
yeah, let me just pull this up for you. So yeah, it'll be a good idea to know all these for everything minus the inclinometer stuff.
Yeah.
Because you're going to need to know that for that final bit there.
Mm-hmm.
But the only thing you're expected to turn in for your spine lab grade is this here. So the movement analysis,
Mm-hmm.
the postural assessment. So you'll have to, and you'll fill in on all these. And again, you only fill in where there's something wrong.
Okay.
And the post-lab questions. And remember, with the post-lab questions, don't worry about that second part here, the research
Okay.
technology. Don't worry about that part.
All right. Thank you for the clarification.
You're welcome.